Hello and welcome to Health Show with Amara. Another health related topic, and today we are going to be talking about patient safety. And what does that mean? Patient is our priority, and their priority means that we are supposed to respect their dignity, their confidentiality, and most importantly, safety. So what does safety mean? Patient safety is about avoidance of unintended or unexpected harm. And of course, as healthcare professionals, no one intends or means to cause harm to patients, but every now and then in the media, we see a lot of stories that create a lot of hype with regards to wrong procedures done. Sometimes wrong side limb has been amputated. And not long ago, we heard a story in the press from Pakistan where two women with similar names had different operations that they were not meant to. And of course, what media does is creates such a hype that just to make it a very sensational news, because public likes that. And most of the time, the blame comes to doctors because they are held responsible. And we have also heard that a lot of doctors, they have been harmed as a result of the anger patients' relatives have towards the wrong publicity, and it's their reaction. Not always it is the fault of a doctor, because it could either be an organizational or a system failure or lack of communication. So although I talked about an incident in Pakistan, but that doesn't mean that these incidents don't happen in the Western world. Here also, every now and then we do hear about the same scenarios where wrong procedure done, and therefore NHS is very focused on ensuring patient safety. So to discuss that in detail, we have invited in our studios today Mr. Amir Khan, who is a surgeon, but also a former medical director and lead for health and safety in his trust. He implemented guidances in his trust to ensure patient safety and so that this kind of incidents could be avoided. Mr. Amir Khan is not only a clinician, but currently he's also a president of APNE, which is the largest democratic organization of Pakistani physicians in Northern Europe. Let's welcome Mr. Amir Khan. Hello, Mr. Amir Khan. Thank you very much for your time to come and join us in studios to discuss such an important health-related matter.
Thank you very much, Amara. Thanks for inviting me. And as usual, it's always great talking to you about things. I think it's a very important part of our jobs as well as a responsibility which we have as physicians. If you say you talked about that incident which happened in Pakistan, and it was actually sensationalized, right? And as you rightly said, the blame is always put on the doctors. It's not just the doctor, it's a team, and a team matters. And Pakistan is not in isolation. It happens all around the world. If I take you back 20, 30 years ago in this country, there was a lot of, if you remember, the patient who had the wrong kidney taken out. And when it was investigated, when they looked into it, they found that in the theatre team, there was one student nurse. When she was interviewed, she said she wanted to ask why you're taking the right kidney, not the left one. But she couldn't, because there was a fear from surgeon, and surgeon was considered to be God, so no one wanted to question them. So I think it's more to do with the team. And I'd like to give this message very clearly to your audiences and my friends that it is the team's responsibility. And I think patient, as you said, is important. That's a center point. And all our services should be geared to provide the best possible health care in a safe environment to the patients and treat what they've come for. Because of these incidences, what I keep on telling people is that don't sensationalize or victimize anyone. I think no one does it deliberately. Okay? No doctor or no human being gets up in the morning that I'm going to go out and harm someone. Things happen. and these happen because of environment, because of circumstances around you. What we need to do is we need to learn from them, right? We need to discuss them in a no-blame culture where people are open about things. They can tell us what happened, and then we should make changes in our system. And the only way you will change system would be by recognizing that there is a problem, right? And that problem can be addressed. So if you look around, the patient safety actually doesn't just start in theater. It starts the day you see the patient first time, right? As a doctor, what's my responsibility? My responsibility is to first diagnose the patient, then explain the treatment options, right? Try to make sure patient understands it. We shouldn't use medical jargon in it. It should be very simple, in a simplistic language which a patient can understand. Look, even as a doctor, when you go to the doctor, if you got a clinical issue or a problem, when you go to see a professional, when you're told the diagnosis, a lot of things just sky above you because you're lost. So it's our job to make patient comfortable, make sure they understand it. And I think I'd stress a lot on that because people don't give much importance to the consent. I think it's important for us, first step is to explain to the patient what's wrong with them. Then it is what are the options of treatment. And then also what happens if we don't treat it. Okay? And then once you've done that, you got the patient at a place where the patient understands it. And then what you do is you discuss with them what is involved in that procedure. Okay? Once you've explained the procedure, then you need to tell them what can go wrong. Right? What can go wrong in an immediate period and also what can go wrong later on in their life. Okay? And again come back to it, that if they didn't have the procedure, what will it do? Okay? And then also I think we need to help the patient to reach the right decision. We give them treatment options, then we decide what the decision should be. It's very important at that time when you consent the patient that you mark it, whether it's left or right, you write it. Okay? Whether it is arm or it is a leg, right? So you make those clear cut on the patient's notes. So you've done that. Patient is gone. And then we talk about cooling down period. We always say, when you see the patient, you give them information. Let them digest the information. They take time for it. Give them, there's so much resource on the internet now. Give them different internet sites where they can see them. Then bring them back. And that's the time you should be.
What I'm understanding is that it's not meaning the consent on the day. Patient should be counseled with regards to the intended surgery in advance of the operating day so that they have understood it well and they're aware of the pros and cons and the implications in the later life and so on and so forth. So how do you know that patient has actually understood even if you have spoken to them in advance?
Very interesting question because we've asked this question several times and I asked myself as well. I think it's my responsibility to make sure that the patient understood it. I shouldn't just take it, I told the patient. No, guys. If you use medical jargon, patients won't understand. They don't know what you're talking about. I think make it simplistic. Make them understand. If there are procedures which might have an impact on the rest of the family, make sure they understand it as well. You need to involve all of them. And then you make the right decision. Doctor's job is not to make a decision. Doctor's job is to help the patient to make the right decision. So we should take them through that process. Okay?
Yes, it's a patient care starts, the journey starts from the day you have actually consulted the patient and decided on the right treatment based on their clinical condition and then counseling them. So consent, you're telling our viewers that consent is a very important part of the whole patient journey to ensure that good care is provided to them and they have understood the procedure very well. So after they have been consented and let's say the day of the operation, how do you make sure that they have well understood and now they're ready for the surgery and the procedure you're planning is going to go safe? Because surgery saves lives, but at the same time, sometimes any little glitches during the procedure may cause harm. So how would you ensure when you're operating on patients that everything is safe Because it's not all about you, it's about the teams as well.
Yeah. I think as you were mentioning earlier that look, these incidents don't happen in just third world, they happen in Western world as well. But the difference is in Western world we learn from it and we try to investigate it and we try to implement changes. So that's what happened here. If in early 2000, a lot of work has gone into it for patient safety, and that's been internationally, it's been accepted, that work has been shared with everyone around, and on that basis we made changes. So what we talk about is the patient is coming in the morning, they are admitted, right? The person who's admitting it should be checking the consent form again. That consent form should be rechecked with the patient to make sure that they are still happy with that procedure to go ahead, right? And what that procedure involves. And the job of that person also to make sure the patient understood that. Then you mark it, right? And that mark should be indelible. Something which should not come off when you just clean it.
So you mean there is a checklist that you follow?
Yes.
So what is that checklist called?
It's called a WHO checklist,
okay.
WHO checklist. World Health Organization has approved that checklist, and it's been actually tried and tested. And it's been, you don't have to follow it to the letter, but you can adapt it to your local circumstances. So on that checklist, first of all, if you were the person who is handing the over patient to me as a theatre staff, we'll both go through with it. We'll ask the question from the patient that do you understand this operation? Do you know what you are coming for? Are these your signatures? Are you still happy to proceed on with it? Do you have any questions in your mind? Then we check that the patient has had if you're going to be a VT prophylaxis or any antibiotics or anything else which needs to be done has been done to the patient, depending on the type of procedure, right? And that's all marked on it, okay? Then that patient from there is taken to anesthetic room. Again, before the anesthetist put the patient to sleep, there's an anesthetist there is a surgeon there, and the staff nurse there. And they again ask the question from patient, are these your signatures? What are you coming for? You check the hospital number, you check the site has been marked or not. Okay, so that you've gone through that area. Then the next phase is, if I just take you back a little bit, we call one thing which is called a patient huddle, theatre huddle. You see, it happens everywhere else in our life. You know, you go to an aeroplane, what happens? They all meet, the whole crew sits and goes through with all the checklists, but we didn't do that in medicine. Although, okay, they have got, if a plane crashes, it's hundreds of people go at the same time, whereas when things go wrong in theatre, it's one person, but one person's life is as important as 100 lives. So what we've introduced is that in the morning, once you've seen all the patients in the arrivals lounge, you all come back to theatre, the whole team gets together, we all introduce each other, right? Even a theatre assistant or anyone who is a trainee or a student should be introduced. So they all have a voice, right? And then once you've done that, then what we do is we go through each and every case. We discussed what that case is, what it involves. First, the surgeon tells what equipment he's going to need, right? And what procedure he's going to do, what order he'll need those things. Then the anesthetist tells you what anesthetic he's going to use, what tubes require, what medicines require. If the patient has got any comorbidities, you go through that. Is there anything specially we need to be careful? Like, just give you a simple example. You know, you put diathermy pad, you need to make sure it's not near the metal. So you need to know if this patient had a hip replacement on the right side, so you don't put the pad on the right side. You go with the pad on the left side. So those are the simple things, but they got to be checked. Then you look at the marks on this is in the huddle. And then at that time, you make sure the equipment is available. There is no point of bringing the patient, put the patient to sleep, and then they realize that you didn't have particular prosthesis or particular equipment. That's too late because patient has already been harmed by putting them to sleep. So all those things are checked and everyone says, yes, we are okay now, we know what the order is. Then you go and bring the patient. Coming back what I was saying earlier, you check at the arrival lounge, then you check again and the anesthetic room before you put the patient to sleep. Then the patient is put to sleep. Then again, patient is brought onto the table. At that stage, everyone stops and rechecks everything. Patient's band is checked, patient's unit number is checked, name is checked, date of birth is checked to make sure it's the right patient. Then what you check, what operation they are consented for, and what operation was the same as it was scheduled or something different. So you check that. Then you check the mark on it to make sure the patient has been marked. Okay. Also at this stage you check again that did the patient have a VTE prophylaxis, which is venous thromboembolism, again something which harms patients. So you check that's been done. Okay. Once you've checked all those, then the patient is put to sleep. At this stage, then the anesthetist, then the surgeon can go and scrub while anesthetist carries on with his bits. Okay. So these are simple safety checks. So once you have started the procedure, you do the procedure. At the end of procedure, it's very important to have a feedback, right? In that feedback, we go through what we've done, right? Was that the right thing? Did anything happen? Did everything go according to plan? Or was there anything which went wrong? Like best example I can give you is swabs. You got to count the swabs because we use them and we don't want to leave them inside the patient because that's a foreign body. Okay. Again, another important point in the checklist which has been added bit later on was that, when you open a prosthesis, you have a timeout. Everyone stops talking because you worked in theaters. There's so much noise. Everyone stops and we have a look at the prosthesis or whatever you're going to use. Check the expiry date on them. Make sure that's the right one. It's the right side, not the left side, because that's happened quite often. That left knee or right knee get confused easily. So you check that it's the right side, and then we call it a timeout. That every time you're going to put something into the patient, you have a timeout. That everyone stops. So these are important parts. The feedback at the end is so important, in which you make sure that procedure is completed. There were no issues during the procedure. Staff knows about it. They all sign it out. And you also make sure that if the specimen has been taken, it's been put in the right pot. There is a right solution in that pot, because there's no point of taking someone's specimen out then putting it in a wrong pot. If you put it in a saline, it might just go completely black and dead tissue afterwards. You don't want that. Yeah. So you need to make sure all those things are done properly. And then what you do is that you check that all the sites have been covered. You make sure where you put the diathermy pad that's been taken off and there's no damage at that place, and the patient hasn't come to harm. And when you're lifting the patient off the table, the whole team needs to be involved. Okay? These are very simple changes. And at this stage, then you have to hand it over to the recovery staff. You tell them what this procedure patient had, what to look for, and what sort of fluids are running through, right? And whether the patient's had antibiotics or not, whatever. So you give those instructions. So these are very simple measures. They look very simple, but they make a huge difference to patients' outcomes.
Yeah, I mean, it all sounds great, but looking at how the journey starts from patient's admission until the surgery is done and later on, thinking about checking all these steps, do you think that affects the time that it takes to complete one procedure? Because especially, we hear about these long waiting times and all that. So does that also contribute to us having these long waiters who are waiting for their procedures for more than a year sometimes? Do you think these checklists, they have influenced that delay in the patients receiving their care in the timely manner?
Mara, you've raised a very important point. I'd only say this much on this one, that look, what's important here? Is safety important? Or is it important that you do 5 operations instead of 4 operations in a day? Yes, it has added time, because prior to that, we didn't used to check these things. And we are disasters. There have been incidences where patients have been harmed. So when you talk about safety, you have to. And the other thing is that it sounds a lot, but once you do it routinely, it becomes a routine process. So routine things are a part and parcel of the work we do. Ask the patient what's important for the patient, to have an operation today or to have an operation safely. I think it's a safety which
absolutely. Safety is our NHS motto as healthcare workers. Patient comes first and patient safety is paramount. So going back to this WHO checklist, of course, this thing has evolved over the years. Would you like to tell us a bit about the background of when the WHO checklist was introduced And since it has been introduced mostly in the Western world, has it made any difference to the number of incidents we see per year?
Yeah. It's very interesting because as the WHO checklist came in, there also a list came of never events, right? Never events are things that should never happen. It's not that they're acceptable complications, they should never happen, right? So both have worked side by side. Never events have gone down since this has been introduced. We haven't completely eliminated it. Still mistakes can happen, but this has actually reduced the incidence of that, reduced the incidence of serious harm to the patients. Because it was, I think it was 2007, 2008 when it was became a part and parcel of NHS, although the work has been going on and before that one on it. And I think overall, it has reduced, it has made our service safer. You raised a very important question earlier. I wanted to mention on that one. You talked about time and delays, which are caused by these, because people use that argument a lot, that these checklists have delayed things over time. We need to learn. You know what happened was, there were very serious incidents. This happened in ENT, ear, nose, throat, right? It was a pilot who took his wife to the hospital, right? It was a day case procedure. He left, he gives a very good story when he narrates it. But he said he left his wife and he, from there, took his little children and they went to the shopping because they were going to finish the shopping, and by that time her procedure will be finished. They'll come back, pick her up, and then go, right? Unfortunately, he got a phone call, could you rush back? He came back to theatre, a hospital, and he was told that his wife is in coma. When they investigated it, you know what they found? There were people standing there, there was a tracheostomy tube available, but no one thought of doing a tracheostomy, right? This man did not sue NHS. He made it as his life's ambition to talk about safety, right? He went around the world giving lectures on safety. We need to learn from airline industry. They do safety checks. In the morning, you would not sit in a plane if you knew that pilots haven't done the safety check. They do the safety check. It takes time. Then, if you talk about time in theatres, learn from F1 with the Formula race. How many seconds does it take to change 4 tires? Because everyone knows their job. They just get on with it and do it. Similarly, we can be safe as well as make sure that we don't waste time. It's the right people as professionals. If we as professionals are involved, I'm very much against it, someone else from outside, a manager coming and telling you what to do. I think it should be us lot. We who are professionals with our teams, all nurses and doctors, porters, everyone is very important. We should all do it. Give you a very good example of that one. This is from, I think it's from NASA. There was a famous story which they told that JF Kennedy went to NASA and he found there was a sweeper who was sweeping the floor. He asked the sweeper, what are you doing? You know, sweeper did not say he's sweeping the floor. He said he's putting a rocket on the moon. And that gives you a very, everyone is important. Every member of the team is important.
I agree with you, Mr. Khan. This clinical example that you quoted, I think working in healthcare system, we all have seen that video, this gentleman talking about the event leading to his wife's death. And in that particular case, we found that there was a lot of opportunities, missed opportunities where theatre staff or nurses, they felt that something could be done, but they didn't feel confident enough to raise it in front of a very senior clinician because the hierarchy came in the way, and she felt that I am so junior, if I say that, he may feel bad and I may be in trouble. So she didn't mention it there, but later on she did say that she felt that she could have offered. So do you think that in working in UK, working as a team, it's very important to get rid of these hierarchical differences between this doctor or nurses or even healthcare assistants or even porters. So would you like to tell us about how system works here?
Yeah, it's very interesting because I'm from the generation when the surgeons were gods and no one questioned them, to be honest with you. And no one would dare to say anything, as you said about that one, that one of the small persons standing in the corner wouldn't say a word about it and question them. That has changed. And I think that is what's the biggest change which has happened in our system. I think, as I said to you earlier, it's a team. It's not an individual. And that's the other part, that when things go wrong, it's the team's dynamics. It's not an individual. No one gets out of bed to harm someone. It's the team dynamics, circumstances around you, which make these things happen. And that's where I think one of the biggest changes which has happened in the UK is that the team dynamics has come on now. I can be challenged by a first-year nurse, right, that this is not right. In the past, when I was training, my bosses, forget it. No one would dare to say anything to them. Those things have gone now. And I'm afraid it is still in our part of the world, right? That has to change. Each person is important. As that story from NASA, when Kennedy asked that question, everyone is important. If the floor is not clean, your patients are going to get infection. If the nurses don't do their job, it's interesting, nurses tell you the swabs are correct at the end of the operation. They're doing you a favor. It's not their responsibility. It's your responsibility as a clinical lead that you take that responsibility. It's a favor they do to you. Yeah. And I think it's important. Team dynamics are very important, and we need to work on the teams. And we need to, I'll stress again and again, don't work on a blameless culture. Don't blame people. Try to learn from it. Because I tell you, when things go wrong, the surgeon goes through a hell in their mind. But make them, if it's a teamwork, make them a part of the team. And let's all share the responsibility and make it best and safe for our patients.
Yeah, I agree with, as senior clinicians, you may be the team leader, but the job of a leader is to take the team with them, yes, rather than to exclude them and dictate. Yeah. So as you rightfully pointed out, that colleagues from back home, where we all belong to, they are very well aware of the importance of these safety checklists. But on my recent visit to Pakistan, I was speaking to a few of my colleagues, and I wanted to check how they make sure that the procedure is done in a safe manner and patient checks are done properly and all that. And they actually highlighted that in Western world it's very easy because all the surgeries we performed, it's all planned in advance and there is a teamwork and all that. But over there in those countries, there is not necessarily, in most of the hospitals, they work on the day. They perform surgery on the day when patient arrives with the problem and all that. And in those situations, ensuring patient safety is more difficult because the number of procedures they do is far more than what we do here in UK. So do you think that implementing the WHO checklist in those developing countries is a feasible option?
It's not difficult. You need to have a will for it. And you need to, first thing is, people need to understand why they're doing it. Is there a need for it? Once we agree there's a need for it, we understand the reasons why we're doing it, it's not difficult to implement. I tell you, the strange thing is, in Pakistan, I operate very regularly. In Pakistan, I go regularly. Other than very few hospitals, majority of the hospitals do not have wristbands. So you don't have patients' details there. Once the patient is asleep, no one knows what it is, who the patient was. I think that's where the system needs to evolve. And emergency surgery or emergency treatment, it's more important to have safety checks, because that's when things go wrong more often than others. Electives are different. And I think we do that in NHS. We have the same system checks in our emergency patients as we have in electives. Same thing happens. The surgeon has to come and tell the team first before they send for the patient. These things, although people feel they're time consuming, they save you a lot of hassle afterwards. You remember that old proverb we used to say, stitch in time saves 9? I think we need to work on these things. We need to make sure that we inculcate that culture of safety. Look, problem is that what I feel really sorry when I go to Pakistan regularly, not just in the hospitals, outside as well, human life is the cheapest thing. We don't care about
Sadly.
it, and that's a sad part of it. Human life is very important. You are sent to this world, okay, there's a life after, everything is there, but you are sent to this world to do something. We need to value that life, and we need to make sure that the life can deliver what we came on this world for.
Absolutely.
And not take it lightly.
Yeah. Mr. Khan, you mentioned about never events, and even though the WHO checklist was implemented back in 2008, I think, but it's still evolving because in the recent years, in the trust where I work, we had an incident where a patient was sent home with a swab in situ. And even though safety checks were done, but yet these things happen. So subsequent to that, we made a guideline where these bans were put in. If a patient has got a swab in situ for whatever reason it is, they have a band which will be removed after the pack is taken out. So these are simple things, but they make a huge difference. But I mean, no matter how many safety precautions we take, still things happen. And luckily, we are very fortunate that in UK, whenever something like that happens, as you mentioned, that we learn from mistakes. There is no such thing as blame game. So, but unfortunately, you know, we hear stories from developing countries where a doctor has been murdered or seriously harmed because the grieving families, they always put the blame on doctors. Do you think it is fair that doctors should be treated like that?
Amara, the problem is that is a cultural issue, and I think it happens in every developing society. And there are two ways to improve ourselves. One is that we go through the same rigmarole to get there, and the other thing is we learn from others what's good. I believe on the second one. I think we should try adapt any good practice and try to make changes in our own system. And I think we should try to, rather than making an individual responsible for these things, we should actually look into it. Because you mentioned about never event, right? One of the never event is like, just give you a couple of simple examples, like no foreign material is left inside the patient. As you mentioned about the swab, all swabs have a ray tag on it so that you can x-ray them if you need to be, whereas back home they don't. They are simple swabs. And the interesting thing, you talk about the ban. When I was in Pakistan last time, the scrub nurse was putting clips on the gown, her own gown. I said, what are you doing that? She said, every time you put the swab in, I put a clip here.
All
so
right.
if you take the swab out, I take the clip off. What we do here is, rather than clip, we write on the board. If a swab has been used, 5 swabs, they're written on that. If the swab goes into the patient, they write on the board. And they rub it off once that swab has been taken off. So I think you need to, as I said earlier, WHO checklist is there. It's been approved by World Health Organization as the right type of a tool, but it has to be adapted according to your own needs. And I think we should do it according to our own circumstances. I'm not saying do everything what is done in what, pick up the best, good things and try to implement it. And I think we need to realize that it's not the numbers, it's the quality which counts. Yeah. And I would more stress on safety and quality because my patients expect that from me. Look, what does my oath tell me? I'm going to provide the safe and the best quality service to my patient. If I'm sacrificing that because I just want to get the numbers through, am I being honest to myself? I'm not. And I think that's where we need to change.
Yeah, absolutely. So, as a former medical director and safety and quality lead, I'm sure most UK hospitals, they follow a very robust clinical governance structure. And how do you make sure that staff who are involved in an incident, they are not taking the blame and they don't feel that they are victimized or targeted because something went wrong? And of course, like these mistakes, there can be human errors. And whenever we talk about an incident, it's not about pointing fingers to an individual. It's most of the time system failure. So how do you ensure that staff are supported and they are given this assurance that they will not be targeted or victimized if something goes wrong, even though it's not intentional?
Yeah. I think the way the governance structure, when I was MD and even in now my trust, the way it runs is that we have a safety meeting every week, right, which every department holds their own safety meeting, and then they are fed to the Quality and Safety Committee once a month. We look at all the incidences. The way the incidences investigated are that the whole team is involved in that investigation. Depends on the seriousness. They're graded: minor harm, moderate harm, or a severe harm. So I think I quite often stress to people, minor ones are very important because they are near misses. Near misses is an area where you need to put more pressure on, because next time it might not be a near miss. So we try to get the team together. Everyone is allowed to give their statements, and then there's a person who is chairing that team, usually one of them, not one appointed by the hierarchy, and then they come up with the proposals that what happened, what harm came to the patient, and what we learned from it. I would include with this one of the things which have been recently introduced in UK as law is called DOC, duty of candor. Yeah. If you remember, it used to be in the past when I was a youngster, it used to be open and honest. We lived in an open and honest culture that we'll be open with our patients. But now the law has mandated that duty of candor is important, that if something has gone wrong, which has caused harm to the patient, or was not planned and it happened, it's my job to make sure that I tell the patient and the family. Okay? If it's a moderate to severe harm, I need to do it in writing as well. If I don't do that, my indemnity insurance will not back me. And that is important. Yeah. That's being honest and open. And people feel stressed, right? Yes, I accept when a lot of people used to say, and that's happened in reality, that the number of litigations have gone up because people know more about it, although no harm has come to the individual, still it goes on that. But that stage, you have to go through that. It will happen. Yeah. But people will realize that what was this introduced for. So I think worry is that we pick up one silly example and we want to stop the whole system. Yeah. No, we should not. Being open and honest is important. Look, as a clinician, I enjoy the trust of my patients. The day I lose that, I should stop practicing. Yeah. And I tell my patients that, look, guys, if you don't, it's very interesting. I used to do seminar every time when the new lot comes in. As a medical director, I used to come and give them a lecture. There was one punchline which I used every time. I used to say to them, if you meet a stranger, would you give them your wallet? You will not. But these patients come and give their life in our hands. We are strangers to them. Yeah. Is the life more important or wallet more important? So just look at the privilege we've got. Absolutely. As doctor, this is a huge privilege. It's our responsibility as doctors to put in systems in place that patients do not come to harm. Yeah. And no matter what it costs or what time it takes.
Yeah. And like we are discussing that no one intends to cause harm, but when harm is done, being open and honest and everything in black and white, telling the patients that this is what happened after we do the investigations. But I wouldn't name the trust, but in UK not long ago, there was a trust where investigations were carried out by the people within the same department, and literally they were, even though they were, they highlighted a few shortcomings, but it was just swept under the carpet, and no one actually found out what happened. And later on, one case became, somebody was more vigilant, and when it took the media publicity, every single patient treated in that trust also started thinking about, and it came to the light. So how do you make sure that when the investigations are carried out, they are done by people who are not friends with those who were involved, and just to avoid that openness?
I think that's a learning exercise, and I think people get to that. And I've always said to people that if you put in a position of that type of position where you are chairing something, it's very difficult to be dishonest, because you have to be honest to yourself, no matter how good your friends are. And I think people forget about that part. And as I think majority of colleagues, I think they're honest. Majority of people who are working, junior or senior or nurses, doctors, portraits, they're all honest, I think. And I think it's a cultural development. And if we provide the right environment, people will get better. You've just talked about that in hospital investigations. You see that the recent awful case which has happened, which is in the paper media yesterday, that the nurse who's been charged as the biggest child murderer of this century, the consultants raised the issues, and the trust did not take them any action. They made consultants apologize at that time, but now it's coming to haunt them. And the thing is that things can't stay hidden forever. It does expose, and I know odd occasion people will feel victimized, people will feel being done badly, but those things should not stop us from progressing or making steps in the right direction. You will have people who would suffer because of that, but at the end of the day, you're going to benefit in the long run.
I mean, I think what we see now is that the system actually encourages whistleblowers, if they've got any concern, to highlight it. And but still, sometimes whistleblowers, they feel that if they bring any such concern to the attention of the management, they may be targeted and they may be victimized. So how do we make sure that staff are encouraged to raise their concerns if there are any, rather than feeling scared or have the fear that they will be sacked or targeted if they bring it into their attention?
Actions speak louder than words. And I think it's a culture in the organization. There will be organizations who are fantastic in that, and there are organizations who do very badly. And I think this is something which over a period of time will get better once it's started. But I think it's a journey. And as we talked earlier about that still never events happen in NHS, in spite of checklists and everything. But yes, if it happens once, you try to make sure it doesn't happen again and learn from it. And I think people have to, in spite of the best safeguards, accidents happen. And that's where we need to treat it as an accident rather than something intentionally done.
Yeah. So all this is so important, and as healthcare professionals, whether we are doctors, nurses, midwives, or any other person working within the system, do you think it is very important that all these things, they are engraved in these people during their training? Because GMC code, Good Medical Practice Guide, we teach students during their med school, and all the learning from there is about improving communication, teamwork, honesty, and trust. So all these things, so even though we talk about it, but what message would you give to our young viewers or even colleagues to ensure that no one wants to be involved in these incidents, because they can ruin your career? Any serious incident happens, and it's, as human beings, it just affects us big time as well. So what message would you give to our viewers on what to do in situations when things are not going the way they should and there is a lot of pressure? Any advice that you would give as a safety and quality lead? You have done a lot of work on that.
Yeah. I think important thing is be honest and open. Be honest to yourself, right? And make sure that treat people the way you would like you be treated yourself. And if you take that type of care, I think there are less chances of things going wrong. And I tell you, very interestingly, like I've got now almost over 30 years surgical career, and the patients where things have gone wrong in theatre, I've gone back, I've seen those patients several times, I've told them what happened, I've never had a complaint from them. Whereas the ones where I thought everything has gone right, something had happened, they are the ones who complain about it. So it's a communication. Be honest with them and communicate. I'll give you a hint to your viewers, especially the youngsters. One of the common questions in the interview I always ask, tell me the mistakes you made and what you learned from it. In that one, I'm not looking at the mistake they made. I'm looking at their honesty. And the person who gives me a story, because so and so did it, I got no time for them. Because we all make mistakes. But it's a question is remembering your mistake, learning from it, and making sure it's not repeated. and making changes.
Thank you very much.
Thank you.
And what message would you give to our patients who think that doctors are responsible for everything that goes wrong?
I can only say this much, that no doctor get out of bed to come and harm you. We all come here to do the best we can. Sometimes things do happen which are not in our control, right? And it is not an intentional harm done. We try our best. And I also tell my patients that, look, when things go wrong, it's not just that, I know you've physically suffered, but the doctor gets a mental trauma. And they inside, they do feel about it. So that's where it's important to have an open and honest discussion.
Viewers, as we are talking about patient safety within the healthcare system, let's talk to another very senior clinician, Mr. Irfan Akhtar, who is a consultant surgeon and lead for surgical clinical services in his trust, and he's also a former president of APNE. Let's welcome Mr. Irfan Akhtar. Thank you very much, Mr. Akhtar, for joining us today. As you know, we are discussing patient safety. So in your role as a consultant surgeon and director for surgical clinical services, how do you ensure patient safety versus performance? Because there is a lot of pressure on us to do cases more efficiently and increase the numbers so that we can reduce the waiting times. So would you throw some light on how you manage that?
Yes. Assalamu alaikum, everybody, and thank you very much for giving me the opportunity to speak here. I must congratulate you, Amara, for picking up such a valid and such a relevant topic today. And I think it couldn't be more relevant given the circumstances we are facing in NHS at the time when the waiting lists are climbing. I think it has been historic number of waiting times which NHS has ever seen. And current situation of industrial action and things which are happening is not helping us at all. So I think it is two tiers to this question. One is to how to improve our efficiency, and the second, which is even more relevant and even more important, is to keep services safe. Okay, so this is the historic time when NHS is facing some historic number of waiting lists, waiting times, which have surpassed which NHS has never seen before. And this is not getting better, and it is being challenged by the current climate of industrial actions, by the fact that there is severe shortage of manpower, both at levels of senior consultants as well as junior doctors to help us out, and the training opportunities which they get. And on top of it, we have to keep our services safe so that our outcomes are in line with all the developed countries. So I would take both of them tiers separately. Firstly, the waiting times. And I think the waiting times are a known figure for NHS at this stage. And we at our trust have tried to invent some ways to improve it, and that is multifactorial. And we try to map the patient journey starting from the time when the patient is referred by the GP, or it becomes referred because of the symptoms through emergency pathway, and root cause analysis of each little pathway where we can add a bit of efficiencies to that one. And that multifactorial. And we take in terms of the diagnostic pathway, how quickly we can do that, how quickly we can arrange appointments. We have changed the way we used to see patients, and now there are a lot of patients who would not require to come to the hospital. We try to do telephone consultations, we try to do video consultations, and only those patients who would benefit to come to the hospital would come to the hospital. So each little portion is adding more efficiency to that one. On top of it, we have worked very hard and in this current situation to improve the diagnostic pathway, which always is a big bottleneck to improve the patient care and shorten the patient journey in that case. So there are various things which we have done in terms of hiring mobile CT scans, mobile MRIs, recruiting private sector for that one. So that little pathway, which always used to be a bottleneck, is more lean and efficient. We have done many other things which was not there in previously. For example, the patients are consented, patients are pre-op immediately, and the investigations which come up from the pre-op are prioritized for their journey. So that is the multifactorial factor which we are trying to achieve to shorten the waiting list as much as we can. It still remains a challenge, and I think together with the planning from the government in terms of recruiting more doctors, retaining more doctors, trying to use the talent of the senior doctors and that let them not retire immediately, and that succession planning is in place, and that these all factors which may be small in their own individual capacity, but keep adding, and cumulative the effect is quite useful for that. Coming to the second part of that, which is very dear to me, is to keep the services safe. Uh, the, the the all efficiencies will come to void if the services which we provide are not safe and are not actually effective for the patient themselves. So we try to do what we are referring to nowadays as a WHO checklist, which has got various portions. So any patient who come to the theater will go through 5 different phases, and that is all has been seen time and again, that if we have got a standard operating protocols for delivering such services, the outcomes improve. We have tried and tested this time and again, and I think that improves the culture of working. We promote new people to come in, feel safe when they come in and join in this pressure area. We picked up people who are senior, who have got more capacity, who have got more capabilities to all, and match it to those who are training. And we have a group discussion in the beginning of each day, which is called as the debrief on the list which will go on, and then we sign in, we go for the procedure, then we sign out and a debrief, and all of that cumulatively add some safety. I think what we have to keep in mind is that every year there are about 29 to 30,000 incidences reported in NHS, of which at least 12,000 are simply things which can be avoided, such as slips, trips, and falls, kind of that. But about 2,000 to 3,000 are those which have got serious effects on the patient care or the patient treatment outcome, and at least 300 to 350 are serious adverse events. So by self-reporting, by looking into that, what we have found out is that at least 50% of those are preventable, and hence adhering to these processes time and again, self-reporting, reflecting on those, and learning through clinical governance processes, all of them accumulatively will add better patient care, better patient outcome, and keep it safe for not only for the patients, but also for the staff working in NHS. I think that's a very big topic, but I will give this a brief review of that.
Thank you very much. So just a question. I mean, you mentioned about current environment where junior doctors have gone through strikes and now the consultants are striking. Do you think the patients feel frustrated and they would probably consider it unsafe for them to be coming to the hospital for their treatment because they would think that there will be staff shortage, or senior consultants or senior staff members are on strike? Do you think that will breach their confidence in safety within the healthcare system?
So, Amara, the experience so far, I mean, we have gone through the third or fourth strike for junior doctors, and we are entering into the first one next week for the second strike for the senior clinicians. I think if we talk about the 2 tiers of patient with NHS faces, one are the elective patients and the other are emergencies. The emergencies are emergencies, so I've not seen any difference of patient presentation in that cohort. Obviously, the cohort of elective patients, the elective activities such as endoscopy, such as theaters, such as clinics, they certainly have come down, and patients, whether they're frustrated, I mean, that is very understandable because they have been waiting for their appointments, waiting for their procedures for such a long time, and now they suddenly find out that that has gone down. So it's certainly frustrating and worrying also for patients, and that is very understandable. The interesting bit which I've seen is that uh, all those patients who have been inpatient during this strike period of time, or who turn up as new patients in emergencies, they have got a strong feeling and strong positive feeling should I say, reassuring feeling for all junior doctors. I've yet to meet a single patient who would come and say that they do not support the cause for junior doctors, and that is in many ways reassuring that public does understand that this process, nonetheless, not a wanted way to go ahead for doctors, and nonetheless, it is not something which we are trained for, which we are geared for, and which we take the oath for. Has become we have reached to a stage where we have taken that step, and so far the public is of full support to that. It is very, again, a very reassuring point that Scotland has achieved something which not only the government offered in a very sensible and in a very considerate way, has been accepted by doctors. And I do feel that soon the government in England should also be looking very considered way in the demands, which so far public has got full sympathy for that. In terms of number of patients going down, I would only suggest that it's the elective patients which certainly have gone down, and adding pressure to the waiting list and already existing waiting list, and I see no end to that at this moment.
Yeah. So it's interesting. I heard from some patients that when junior doctors were on strike, they were very willing to come to hospital even with small emergencies, because they knew that consultants are covering. So now when consultants are on strike, I hope that the trusts have made enough arrangements to provide cover for those who are striking, because juniors can't replace the consultants.
Totally agree with that, Tamara. That's a absolutely valid observation from you. Uh, the concept is a Christmas level cover, which would mean that all emergencies which walk through the doors of the hospital would be addressed. So anybody who, I would say that the people should feel confident that if they have got an emergency, medical or surgical, if they come to the hospital, they would be looked after, they would be taken care of, and they would get the appropriate treatment. And there is enough processes, infrastructure in place to address that. Uh, as these things progress, time and time again, I mean, this is the second time the consultants are striking now. I think that confidence, how much of vitality it will maintain to itself, is something which we have to see. I do feel that as it progresses, gets a protected course, the population itself will start feeling about it, and will have the effect of it. But I can reassure from this platform to all public that if there is an emergency and you need to visit an hospital, something which needs urgent treatment, do come to the hospital. You have got your GPs. You will have a consultant cover or a senior level cover to address all emergencies. And I am quite assured that the majority hospitals so far, which I am aware of, have got adequate measures in place to address that.
That's great news, and I hope our viewers actually they feel reassured that in case of any situation where they have to go to hospitals, they will not be neglected and safe care will be provided. Thank you very much, Mr. Akhtar, for your very strong messages, as well as telling us about how our systems work to ensure patient safety within the organizations. Thank you very much once again.
Irfan, thank you very much. I think you explained things quite nicely. Just one of the biggest dilemma for a director in NHS is that NHS is actually a three-legged stool. The three legs supporting it is finance, quality, and performance. When you are a clinical director, how do you put them in a priority wise, and how do you balance them? Because you take one leg out, the stool falls down.
Thank you. Have nailed it very nicely. It is always a challenge. What we have to understand are two fundamental factors as the societies progress, or as the nation progresses. We are turning into a society which is becoming more and more geriatric. People are living longer. The outcomes for cancers are improving year on year, which has resulted into chronic ailments becoming more prevalent. And then there are some ills of the society, such as obesity, diabetes, smoking, and all of them added more pressure onto, onto the general public as large. What we have to understand is that we have to adapt new measures, adapt new techniques, or adapt new ways how to address that. And I think it is it's a national thing. It's not a fundamental problem of a trust or of a university hospital, but it is, I think, a national problem. So I think coming to fundamental things like preventing things such as diabetes control, such as cardiac problems, such as obesity, would make people more safer to come to hospital and have better outcomes on that. And when the patients do come up there, we have adapted measures around the fact that the finances are always are always a challenge to that. And how do we measure that? The HRG codes, as you're aware, the HRG codes are falling down year on year. The block payments which you used to get are now changing into, again, payment by review and payment by procedures. So they are all adding more and more pressure. But what we have to understand is more holistic approach, a more pragmatic approach, that there still is a big pot which is common, whether it comes from CCG or whether it comes from primary care, secondary care, or tertiary care. The main pot remains the same. So what we have to address is that we work more cleverly, more efficiently, and deliver more. And for that, there are factors which what we were talking about, that the manpower that should be reasonably available, the new technologies which have come up which give better results should be made available. The patients turnout, which block our beds in the hospital, should be more efficient. So the social sector needs to be improved. So I think, as the famous coach for the cycling team said once, that it is 1% of each thing. So if we keep adding 1 plus 1 plus each, I think cumulatively we can achieve that. Would it be an easy task? I think it's a challenge. I think it's a well-known challenge, and we face it every day. And I think it is changing the way which we have been working before is the only way forward.
Great. Now, thank you very much. I think you explained it quite nicely, because if we provide a good, high-quality service, you will have less complications, less problems, so your performance will improve, and you will be spending less money on it as well. Because we spend huge amount on insurance indemnity at present, NHS, and if we can reduce that, that will come towards patient care rather than be just being spent on that. So no, thank you very much, Irfan, and I look forward to see you again, and we'll meet again, inshallah.
So viewers, our today's topic, patient safety within healthcare system. You heard the opinion of two very senior consultants working within NHS, who discussed the measures taken to ensure patient safety within the healthcare system. I hope you enjoyed the show. We'll be back with another important topic on health. Goodbye for now.